Okay, so hi everyone. Feel free to unmute yourself and ask any questions or type it in the chat or put your videos on. Either way, just interact if you have any questions. So I'm Nadrata. I'm a graduate entry medic. I'm in my second year and I'll be talking a bit about synapses and epilepsy. So first things first, does anyone have any ideas about how you would define a synapse? Or if you've heard of synapses before. Again, feel free to unmute yourself and speak or type in the chat. The junction between two neurons, that's very good. That's true. Any further take on it? Anything a bit more specific? So what kind of neurons? What would you call those neurons? Okay, that's fine. So a synapse is defined as the site of transmission of electrical nerve impulses between two nerves, and specifically, the nerves can be, as we can see over here. So the one where the electrical impulse is arriving from is known as the presynaptic neuron, and obviously you've got the synaptic gap, the junction, as you mentioned. And then you have the postsynaptic neuron, so the neuron in which the nerve impulse carries on. Now, typically, sometimes the postsynaptic neuron cannot be a neuron. It can be an effector muscle or a gland. And we will go on to talking about that as well in a little bit. So there are specific types of neurons. One of the ones we've seen in the previous slide is a chemical one. So this one uses neurotransmitters, and as you can see, there's tiny little pockets, vesicles, which have the neurotransmitters, the chemicals itself, which diffuse across the synaptic junction. And the postsynaptic neurons have tiny little receptors in which the protein chemical molecules bind to, and then that initiates certain changes in the receptors, which leads to the electrical impulse. There is also electrical synapses itself, and these are much rarer. The chemical ones are typically the ones we predominantly focus on, and are more prevalent in the body. So the electrical ones have two membranes very close to each other, and they contain a special protein called connexin, and this allows direct passage of the current itself. So a common example of that would be nodes of Ranvier in Schwann cells. Any questions? Again, if you have any questions, you can pop your hand up or type it in the chat. Okay. So, these are some of the examples of common neurotransmitters you will find around the body. And each of them, if you can recall, some of them also have corresponding receptors, which, not very inventively, are called serotonergic receptors or dopaminergic receptors, and so on and so forth. So it does use the name of the neurotransmitter to name its corresponding receptors that it binds to. And they are typically, as I said, released at the end of a nerve fiber. And then once it diffuses, it then binds to the receptors. So this is a brief overview of exactly the biochemical process that underpins synaptic transmission. So what we're now going to do is talk through the basic steps and then go into a little bit more detail into each of the steps. So first of all, you have action potential electrical impulses, we were saying, arriving at the axon terminal. So here we've got the terminal. And this leads to sodium channels in the presynaptic neuron opening and causing depolarization of this presynaptic neuron. And this subsequently leads to the opening of voltage-gated calcium channels. So once the calcium channels open, an influx of calcium is what stimulates and triggers the fusion of these vesicles, which carry the neurotransmitter molecules to fuse with the presynaptic axon terminal membrane. And obviously this process is called endocytosis, and it's an active process. So there's a lot of like proteins as well involved within the cytoskeleton itself, to which allow this exocytosis of the chemicals. Once you've got the neurotransmitters diffusing into the synaptic junction or the synapse, it diffuses across. It's really a gradient-dependent diffusion, and it diffuses through the cleft and binds into tiny little proteins, membranous proteins, transmembrane receptors on the postsynaptic neuron. And once it binds to the postsynaptic neuron, you have voltage-gated sodium channels opening up. That in turn depolarizes the postsynaptic membrane now, and this leads to further depolarization, and then you hit the threshold action potential, threshold frequency voltage, and then you get an action potential generation, which then carries on the impulse into the postsynaptic neuron, and then this postsynaptic neuron then will become a presynaptic neuron for its next synaptic junction. So, and the process carries on. That's how you get the neurotransmission. So what happens to all these acetylcholine molecules that are, floating around in this synaptic junction? So these, their fate is determined predominantly in two ways. First is reuptake, and you have specialized receptors in the presynaptic neuron for certain neurotransmitters, especially catecholamines, where it binds to the transporter protein and is reuptaken. And alternatively, and it is the case for acetylcholine, you get degradation of the neurotransmitter, where some of it is then processed back and recycled back into the presynaptic neuron, ready to make further neurotransmitters, and some of the parts are recycled elsewhere. So now a little bit more detail. So in terms of synthesis of acetylcholine specifically, any nerve terminals which have it are called cholinergic. There's also further deviation of that. There's nicotinic and muscarinic, but we can discuss that if we have more time. And essentially it's the synthesized from choline and acetyl-CoA enzyme, which you might be familiar from the Krebs cycle and the link reaction. And these two reactants essentially are catalyzed by an enzyme called choline acetyltransferase. And the enzyme literally describes what the function of the enzyme is. So you have the acetyl-CoA molecule being transferred onto the choline to form acetylcholine itself. And over here you can see the process schematically. Any questions at this point? Nope. Okay, so we'll crack on. So now a little bit more about the release of acetylcholine. So and this is now talking about neuromuscular junction. So earlier on, when I mentioned that not necessarily your postsynaptic neuron will be a neuron, many times it can be a muscle or a gland. And in this case, we're talking about a neuro and muscular junction. So essentially, your postsynaptic neuron is now a muscle. So you have corresponding receptors on the muscle instead of another neuron. And as you have an action potential arriving, you open up the calcium voltage-gated calcium channels, and this leads to the fusion of the acetylcholine molecules. These then move across and bind to the receptors itself. And again, the process is almost identical, except instead of another neuron, you have a muscle here. Now, this is a bit more specific, and we're talking microscopically the changes in protein shape, and what exactly happens to these receptors to initiate a postsynaptic neural transmission. So when acetylcholine binds to receptors called acetylcholine receptors, there are certain domains of the receptor which open up to allow sodium ions to cross the membrane. So as you can see, initially there's a few opening up. So there's a slight modification to the alpha domain in this case, which lets a few sodium cations through. Now, it's a bit like hemoglobin and the oxygen dissociation curve. So how, how oxygen sort of binds cooperatively and you get the shape of the hemoglobin oxygen curve. It's a bit like that. So once you have some of the sodium cations entering, then it creates a sort of an influx and there's more conformational changes to the protein, which results in further sodium ions moving into the cell. And this leads to the general generation of the depolarization voltage. Now, if enough of these acetylcholine receptors are activated, then you essentially reach what we called threshold frequency or threshold voltage, at which point you can start generating a potential. And this is, in this case, not going to be action potentials itself, but it's end plate potentials. The reason why it's end plate is because it's essentially residual current at the end of your muscle cells, and if you activate them frequently enough, then it can lead to an action potential. But initially, you get tiny little voltage movements and currents. If you connect muscle to with a pair of electrodes, then you're likely to see tiny sort of movements corresponding to the slight changes in voltage. And eventually, as I say, if you do open up enough of these receptors, then you can get this action potential, and then that's how you would essentially generate muscle contraction. Now, lastly, a bit about recycling acetylcholine. So acetylcholine is hydrolyzed by another enzyme called acetylcholine esterase, and this breaks it down to choline and acetic acid this time. And the choline is reuptaken into the presynaptic cleft or presynaptic nerve terminal, and it's stored for future use by choline acetyltransferase. The acetic acid then is recycled and is used for metabolic reactions further down in the mitochondria and so on and so forth. This is just for acetylcholine, but you can get other neurotransmitters which are broken down as well, are dopamine, and they degrade into two sort of monoamine oxidase essentially is an intermediate byproduct of dopamine, and ultimate metabolite of dopamine is COMT, which is another neurotransmitter end product. And you also get reuptake mechanisms for chemical neurotransmitters such as noradrenaline. So this is norepinephrine transporter. So this essentially takes up noradrenaline into the presynaptic cleft. So we're moving on to the second part. So far, any questions? Any questions at all? Okay, feel free to pop it in the chat if you think of any later on. So we've now described the whole process and a little bit of details on what exactly goes on in each of the stages. There are certain pathologies we get as a result of disruption to the neuromuscular junction. And this slide is essentially just exploring where some of the problems can start. So out of the different parts, as we've separated it out, so you have firstly the synthesis and storage, right? and this is to do with the presynaptic terminal. So you can have issues with producing acetylcholine. This could be because of a genetic defect, which leads to impaired choline acetyl transferase, or post-translational modifications, which again hinders the quality of the enzyme, which as a result inhibits the production of acetylcholine. You can have a shortage of choline and acetyl-CoA. So these are just some of the things which could affect the production of acetylcholine. Similarly, packaging of acetylcholines, we know they rely heavily on vesicles, and again, a formation of vesicles itself would require certain biochemical processes which can be impaired, and as a result of that, you can have defects of ineffective fusion of the vesicles with the presynaptic membrane, resulting in inadequate exocytosis of neurotransmitters. You can also have issues with release, and again, that would be partly to do with vesicle formation, and also with the whole cytoskeletal system, which functions to lead to exocytosis of neurotransmitters. You can also have issues in synaptic clefts. So you can have issues with acetylcholine esterase, and this would lead to, actually, this is a question for the floor. So what do you think some of the consequences would be if acetylcholine esterase was dysfunctional in a patient? Any ideas? No. Okay, so if we think back to acetylcholine esterase, this is the enzyme that is needed for the breakdown of acetylcholine into choline and acetic acid. So dysfunction of this enzyme would mean that you'd have a surplus amount of the neurotransmitter circulating in the synaptic cleft, resulting in increased firing of postsynaptic neuron. So you'd almost get a state of constant contraction in some cases, which you do see in certain conditions. Postsynaptic terminal, again, issues with binding of acetylcholine to the acetylcholine receptor, and this can be either due to the changes to the receptor, or it can be due to the changes in conformation once the acetylcholine has bound to the receptor itself. And lastly, the causes of some of these defects could be toxins. So you hear about botulinum toxin, which affects vesicular fusion and release. You have autoimmune conditions, which we will go on to, and genetic ones I've sort of briefly explained the principles of. Any questions? Okay. Okay, so we're now going to talk about one of the autoimmune conditions which can affect neuromuscular junctions. So myasthenia gravis is an autoimmune disease of the postsynaptic terminal of neuromuscular junctions. And it's essentially caused by the generation of antibodies against two critical parts of the neuromuscular junction. So firstly, the most common one is antibodies against nicotinic acetylcholine receptors. And nicotinic acetylcholine receptors are, so as I mentioned earlier on, there's two different types of acetylcholine receptors. You get ones which are nicotinic, which are found in neuromuscular junctions. And there's another one called muscarinic, which is the second one over here. And it's a different, it's another form of acetylcholine receptors not found in neuromuscular junctions, but elsewhere in the body. So the ones specifically found in the neuromuscular junction are the nicotinic ones. So they form majority of the cases of myasthenia gravis, although you get some which also affect the latter kind of receptors. And there are also rarer cases where other antibodies affect downstream targets of proteins as well. Okay, so some of the symptoms of myasthenia gravis is drooping of the eyes, known as ptosis, and patients tend to find typical daily activities quite tiring. So things like brushing their hair or just going up the stairs. And the reason why is because you have antibodies blocking these nicotinic receptors, meaning that you won't have acetylcholines to bind to those binding sites because those binding sites are already occupied, resulting in lesser and lesser muscle contraction because you don't have enough nicotinic receptors available for acetylcholine to bind to. So after a point of time, patients tend to get quite tired because they simply cannot bring in the range of movements and muscle contractions needed to carry on with exertion or activities which involve movement. Something typical you see in myasthenia gravis patients is their condition gets better with time, so they feel less fatigued if they rest. So sometimes you'll find patients who've started the day relatively okay, but towards the end of the day, they're feeling really tired, and it's probably because they've used, all of their muscles quite a bit, and often when you're speaking to myasthenia gravis patients, you'll see that initially they start off with normal speech, but over time you see a slowing of their speech and they struggle to just speak to you. But if you give them a rest, then they'll come back to it. And the reason why the rest makes a difference is because once you rest, you give the working existing nicotinic receptors, which are not blocked by these antibodies, to then be reactivated. So you have more binding sites available for acetylcholine to bind to, and then generate action potentials, and subsequently aid with muscle contraction and movement. So that's the basis of it. In terms of treatment, myasthenia gravis typically, well, actually, this is another question for the floor. I don't know if anyone would like to have a go. So what do you think we could use for patients to alleviate some of their symptoms, or at least temporarily? So the clue would be to do with the synaptic junction. So what could we do to the synaptic junction to make sure that patients... Yes, absolutely, Daria. So acetylcholinesterase antagonists or blockers. And this would essentially allow more acetylcholine to be floating around in the synaptic junction, aiding further activation of the neuromuscular junction when active sites become available. And you don't have to obviously rely on the presynaptic neuron to just release. The whole process is a little bit faster. Very good. Any questions so far? No. Okay. So we're moving on to epilepsy. So that's the second part of our talk today. So again, any takers on what is epilepsy? So have you heard of it? Do you know anyone who suffers from it? Or has the condition, sorry. Okay. So epilepsy is essentially a repetitive condition where you get recurrent seizures. And the way the difference is drawn is epilepsies are where you get 2 or more unprovoked seizures that occur more than 24 hours apart. So it's more of like a frequency difference between seizures and epilepsies. On the other hand, seizures, you can get seizures for various reasons due to pharmacological reactions, low blood pressure, um, and so on and so forth. With low blood pressure, I would say epilepsy, if someone does have epilepsy and they come to donate blood, and then suddenly lose a volume of blood, they are more likely to have a seizure. It's simply because of the imbalance of electrolytes. So a seizure is a burst of uncontrolled electrical activity between brain cells, and it causes temporary abnormalities in muscle tone and movement. And the most common ones are known as tonic-clonic. So you have increase in tone and you have clonus movement, which are sudden twitches. You can also have prior to a seizure, if you've ever witnessed a seizure, you will see individuals sort of either looking quite confused or phased out. And usually, if you're someone who's epileptic, you will recognize the warning signs and you will realize that you're going to have an imminent seizure. And you can see from the behavior, they will start. There was a patient where they started making tea or offering their wife a glass of wine just before, and that was their warning sign. So this also explains how different patients will have different warning signs and different preceding symptoms per se before a seizure. So it's really case to case dependent. So some of the risk factors would be age. So most commonly seen in children, and then there's another sort of rise. It's bimodal kind of distribution in elderly people. But technically you can get epilepsy at any age. Family history or strong family history of epilepsy. If you have a patient coming into your practice who says that they've been suffering from seizures and they have a strong family history, then exploring and either confirming or ruling out epilepsy is a sensible thing to do. Head injuries, and the reason why head injuries would play a role is because electrical conductivity is dependent on neurons, and neuronal damage secondary to head injuries and trauma is likely to disturb and the electrical balance of receptors and so on and so forth. And again, stroke, other vascular disease, essentially any form of sort of brain trauma, whether vascular or traumatic or ischemic, is likely to increase chances of epilepsy and seizures. Again, dementias, brain infections such as encephalitis, meningitis can also contribute to epileptic diagnosis, and seizures in childhood as well. Now, there's been some evidence that living in poor socioeconomic backgrounds can lead to an increased incidence of epilepsy. However, the exact cause of why that is the case is still unknown, so that is subjected to further research. So, what exactly happens when you're having a seizure or when you have epilepsy? It's quite literally a shift in the balance between excitation and inhibition in our brain cells, and the way it's governed is by the respective receptors. So you obviously have a neurotransmitter, stimulatory neurotransmitters, which essentially release of those neurotransmitters lead to depolarization of neuronal structures, glands, and muscles, resulting in stimulation and propagation of action potentials. However, you also have inhibitory neurotransmitters such as GABA, which essentially does the opposite. So as soon as GABA is released into a synaptic junction, it binds to the postsynaptic receptors in the postsynaptic neurons, and leads to hyperpolarization of that neuron, resulting in almost inactivation of channels and inhibiting, so preventing the propagation of an action potential. So you get it both ways. And essentially, when we are in our resting state without seizures or without a history of epilepsy, we have a fine balance which essentially maintains our ability to stimulate and propagate action potentials and also inhibit excessive propagation and firing of action potentials. Whenever you have a disruption to this balance is when you get seizures. So if you get, in a brain trauma, you have a part of the brain which is damaged, which is heavy in GABA receptors. You lose that form of big control of inhibitory neurotransmission. Subsequently, you get an increase in uncontrollable excitatory neurotransmission. And this leads to, your tonic firing, your twitching, and so on and so forth. Some of the symptoms and signs seen are uncontrollable jerking and shaking, which is commonly known as a fit. And again, as I said, losing awareness, staring blankly into the space, not engaging in a conversation with someone you were having a conversation 5 minutes ago. And if you touch someone who is showing the warning signs of a seizure, you can sometimes already feel their muscles going tense and them becoming stiff. And yeah, some people have described strange sensations. And again, these vary between patients, and you often do associate seizures with collapses. So anyone who's seizing can often sort of seize to the ground and not necessarily become unconscious, but they will definitely have a fall, and that then raises questions of how would you manage these kind of patients. So you often have sort of cards that patients carry around. And if this happens in public, public knows what to do. And you just manage accordingly. And often patients who are prone to collapses would be given advice around how to be safe in general. If they, for example, see warning signs, then they're encouraged to sit down or make themselves safe so that they don't injure themselves further physically in an event of a collapse. And lastly, you can often pass out and not remember what's happened. So in some cases, you can have loss of consciousness, but it's not very frequently seen. Any questions so far? No? Okay. So how do we diagnose them? Anyone have any idea what this picture is showing? Any guesses? Perfect. Perfect. It is EEG. So EEG is electroencephalogram. So essentially, just like an ECG, instead of it mapping the electrical conductivity of the heart, it's mapping the conductivity of the brain. And additional forms of diagnosis involve brain imaging. So this can range from CTs to MRIs to rule out if there's any sinister causes and so on and so forth. But typically, if EEG results are in line with, and you get certain changes in EEGs in cases of epilepsy and seizures, and when someone's having a seizure. So monitoring someone, especially whilst they're having one of these episodes, it's great because then it shows you what kind of electrical conductivity changes their brains have, which is resulting in the seizures, because not everyone who has seizures have the same changes in their electrical conductivity. Okay, in terms of managements and treatments, obviously, like any management, you have two sort of routes. You have the medical and you have the surgical. So firstly, the medical involves a class of drugs called anticonvulsants or antiepileptics. And you can see there's a range, and some of these medications are used for other conditions. For example, lamotrigine is often used for neuralgic pain, so trigeminal neuralgia, secondary or tertiary medical management of trigeminal neuralgia would use lamotrigine. You have gabapentin again, which is also used for neuralgic pain. You had diazepam, which is often given clonazepam, the ZAM drugs. And these are essentially working on your GABA receptors and stimulating their action. So increasing the inhibitory input in your brain to essentially act as a block for convulsing and to restore that balance between inhibitory neurotransmitters and stimulatory neurotransmitters. And these are often seen, have wide spectrum uses in depression, in sedation, with helping people with sleeping, and so on and so forth. However, these drugs are quite nasty. They do have quite a wide side effect profile, which is why a lot of the times if you have a diagnosed epilepsy, which is pretty bad, you're having sort of episodes every day, 6 or 7 episodes of seizures a day, your quality of life is significantly worsened whilst having those seizures and being on these medications, because you have so many more other side effects to deal with. Things like nausea, things like headaches, constipation. And they really take a toll on life because it's your daily activities which are being impaired grossly on top of, you having seizures. So for those cases, other side effects would also include, obviously, sleepiness, drowsiness because of the sedatory consequences of these drugs. And it can also lead to irritability, anxiety, and essentially become a slippery slope where you might be inducing sort of, if you're using these drugs on a long-term basis, you might be inducing other conditions onto a patient, because someone who came in, without anxiety, just seizures, after being on long-term diazepam, might become prone to anxiety. So that's another thing to consider. So for patients who generally have quite regular seizures, surgical treatments are often encouraged or sort of open to discussion with patients. And there is 2 main non-invasive procedures. One of them is radioablation, which essentially uses pulsed radio frequency to generate friction and vibration and essentially block off excitatory pathways which are resulting in seizures. So there are tiny bits, and again, EEG plays a huge role in targeting those excitatory pathways, neuronal pathways, and they are supposed to be a permanent cure. As to the clinical outcomes of how successful they are again very variable. It's very case-to-case basis. Alternatively, you can almost have, like with the heart, you have the pacemaker. You can sometimes have electronic devices which also sort of send signals, and the aim is to interfere with the signals, which are electrical impulses, which are causing the seizures, and almost have like cancellatory effects. And this can sometimes be more helpful for controlling the seizures. In terms of which of these surgical procedures are better or worse, there hasn't been enough research on them to pinpoint exactly which one would be better. But again, it's dependent on a host of factors such as patient choices, patient comorbidities. For example, if you have a patient who has cerebral palsy and also has seizures, surgical management with radioablation might be a good idea because it's not very invasive and it's a relatively simple process which doesn't require our patient to go through several stages of investigations preoperatively. And these are important factors to consider when deciding on which treatment is best for which patient. And that's all I have today. Any questions at all, or anything that was a bit unclear?